So welcome to this concurrent session entitled Virtual Care, Kidney Care in 2020 and Beyond. My name is Anurag Singh. I'm a nephrologist in Prince George, Medical Director of Northern Health's Kidney Care Services, and co-chair for this year's BC Kidney Days. It's an honor for me to be your host and moderator for this session. I will quickly go over some housekeeping items first. Our speaker will have about 28 minutes, and there will be 10 minutes for questions and answers. You may submit your questions at any time during the presentation. To submit your questions, you will need to use the event app. Once you're on the session page for this presentation and the live Q&A, tap a question now, and then you will type your question. I will do my best to get your questions answered. COVID-19 crisis has forced us to adapt quickly and learn new ways to connect with people that we care. As kidney care professionals, we look after individuals who are vulnerable, yet need regular clinical care. Our speaker today has been at the center of developing, spreading, and standardizing virtual care through our kidney clinics in BC. It is my pleasure to introduce you to Dr. Micheli Bevilacqua, who is a nephrologist in Fraser Health with additional training in health administration. Mike also serves as a chair of the Provincial Kidney Care Committee and leads the BC PKD network. Mike, it's a pleasure to have you here. Over to you.
Thanks so much, Anurag. Okay, great. Thanks, Anurag. Thanks for that introduction. Yeah, so today we're going to be talking a little bit more about virtual care, where it is now and where we see it going in the future of renal care. I have nothing to disclose relevant to this presentation. And there are a few things that we're going to go through. I think before we launch right into virtual care, we're going to start by just reminding ourselves what our philosophy of interdisciplinary renal care is to begin with, because I think that really sets the stage. And then we'll discuss a little bit more about virtual care, both where we've been to date, how we see this moving forward, now and in the future. So let's just launch into it. And again, I think we really need to remember to set the stage. I like this phrase that's been coming out now. People are calling it the before times before COVID, which is from Mad Max, if you're an old film buff. And I think it's a little bit appropriate, dealing with what we've had to in the last year or so. But it is important, I think, to remember where we've come from in terms of renal care. And all of our renal care for many years has very much been team-based. It's a multidisciplinary team is a very, very unique thing. It's not just a collection of different people. It's a group of different professionals all united in the same goal of enhancing our patient care. And so I have people listed here, and I'm sure I'm missing some that are involved in the renal team, but it's a large number of people. And more importantly, it's integrated. It's not different providers all providing care in parallel to each other or independent of each other. It's a team together offering an integrated bundle of care. And that might seem like I'm splitting hairs, but it really is an important difference that's going to come up as we talk about how we support that in the virtual world. And in addition to our team being kind of a complex and integrated group, the care we offer to renal patients is somewhat complex as well. So renal care is unique in that it's longitudinal care. In many of our patients, it's over many years or even decades. But it's interspersed with different events and different trajectories. I kind of like to break up what we offer in our kidney clinics into these buckets of services. So we have some tasks that are more education oriented, either to talk about self-management, things like blood pressure, diabetes, et cetera, or when we're talking about more complex things like renal treatment modalities. So we have our education components. We have at times where we go into what I call autopilot mode or surveillance, where we're kind of just keeping an eye on things, seeing where a patient is at, and then keeping them stable. So that's both in our clinic and between clinic visits. And then at certain times, we'll have our navigation components too. So the most obvious one there being transition to different care modalities. But there are other things they have to access. They have to go see different specialists. They have to get treatments done. So there's a whole bunch of parts where they have to find their way. So that's why I like this picture of peaks and valleys, because that's really what our renal care is over the course of someone's lifetime. It's not one steady or constant level of services we're providing, but it goes up and down in these ways. And in addition to the trajectories being complex, the way we interact with our patients is also complex. So there's not one set way that we interact with our renal patients. And that's another kind of key thing here. We have our clinic visits, which are quite set and standardized. But in between visits, that's, as all of you know, that's where a lot of the care actually happens. The phone calls in between, patients are going into a hospital or seeing a different provider in between, and we have to make some changes. So there's a lot that happens in between outside of the clinic setting. Outside of the clinic, we'll bring them in for sometimes some formal education sessions, a treatment modality session or a transplant session, or there might be some informal sessions that happen. And then throughout all of this, we need some way to document what's happening, both so our own team knows what's happening, and so the other providers who care for this patient know what's happening as well. And that happens in many different formats. Sometimes we have paper charts in our clinic, sometimes there's EMRs, there's promise, and there's some combination thereof. So it's not any one set way that we interact with these patients. So if it sounds like I'm trying to make a complex picture here, it's because I am. And the reality of it is that care for renal patients is quite complex. We all take it for granted a little bit because we've been doing so long. But when you start thinking about these actual components, there is a lot of moving pieces here. And those are all the pieces that feed into our multidisciplinary clinics. And it's important to say that, we're not just talking about this because it's the way we've always done things. There is good evidence that this improves patient outcomes. And I don't have time to go over it all here because that would be a whole talk in and of itself of just what multidisciplinary CKD care does for people. But we do get them to a better place. And you can see here that when we paint this picture of all the care tasks that we do, all the providers that we have working together as a cohesive team, those are the things that are leading to our improved outcomes. It's difficult to say just exactly which component of this is what's leading to the positive outcomes we see in our patients, but we know that offering the care in this way is better than any one provider alone can do. And then we had to change everything. And it's important, I think, to recognize that this is not something that we decided to do. That sounds obvious, when I say it out loud, but the reason I'm making that point is that if this was a planned body of work, we would have had a strategy, we would have had an evaluation plan, we would have made, precise changes and then decided and then documented what happened afterwards. Whereas that's not at all what happened here. We were dealt something we just had to change rapidly. I'm not going to go over all of this in detail and just all the ways that it's changed because I think everyone's quite familiar with this, but sometimes it is worthwhile to reflect just how much has changed or how different this is compared to where we were just 6 to 9 months ago. So there's the whole aspect of having changes in configurations of our clinics, reduced access to providers. That one I think is key that we're recognizing more and more. There's both real reduced access and perceived reduced access. There's reduced access to our kidney team, and some patients are struggling with reduced access to their primary care providers. And the combination thereof can be quite a difficult one to manage. And there's a whole host of human factors. And I want to list that one because I think we all think about the ways that our formats and our clinics have changed, but there's also the impact it's had on people. Our patients are a very heterogeneous group of people. They all come from different backgrounds. And because of this, they have different ways and different comforts in accessing our new methods of care. Our team members themselves also have different levels of comfort and different level of ability to adapt to these. And even 9 months out, everybody's still, I think, a little bit anxious and uncertain. And it's important to recognize that because that does play into what we're expecting of people. So we've talked a little bit about where we've come from and all the changes that have happened. I think now is a good time to take stock and say, where are we in terms of virtual care delivery? This talk for Kidney Days was planned many months ago. They had asked me to give this, and I was expecting that by this point we would say, oh, well, we're all on one platform and we're doing video conferencing in such and such a way, and we'd have a pretty set package that we were offering. And of course, the real world has a way of kind of interfering with any plans you might want to lay out. And so I think it's worthwhile of just saying what is the current state, and the real answer here is that the current state is very variable. And this isn't a fault of anybody's. This is just the way that things happen when you're essentially adapting rapidly to an emergency. And it's worth reflecting on some of the types of variation we're seeing out there. As we're bringing more people into clinics, some people are able to bring a lot of patients in physically again. Others have very few who are coming in. Some clinics have completely adopted video conferencing solutions for all of their remote clinic visits. Others haven't. Others, for all their remote visits, are still happening by phone. For those who are using these virtual platforms, sometimes it's the same platform that all the team is using. Sometimes different members of the team are using different platforms. One of the biggest sources of variability is the level of support that clinics have. Being in a position where I can kind of see what's happening across the province, I can tell you that some health authorities are very, very well supported by their virtual health teams, and some that support is very, very little. They have very few people, and they're stretched quite thin. Some people have essentially taken their old workflows and just plugged it into a virtual world. Others have created completely new clinic workflows. And we're still in a situation where we have some providers who are working from home and others who are working from clinics. And you can see all these dimensions of variability, and I'm sure some that I've even forgotten, make it so that the way that our services are being delivered are quite different from clinic to clinic. So when we're talking about what is virtual health right now, it's not any one thing, it's a combination of various things. So I hope I'm not making it sound too complex to get a handle on, but now trying to put these items together. How do we bring that previous philosophy of multidisciplinary renal care that we've had for so many years, it's served us so well, how do we bring this into the virtual setting? I think this is the item that we really want to talk about here. And we've always had this concept in the past when we're talking about treatment modalities of finding the right treatment for the right patient at the right time. And so here the mantra that I'm going to when we're talking about virtual health is that now we have to also think about how do we find the right visit type for the right patient at the right time. And this is a decision that we're going to have to make over and over and over again, essentially every time we're interacting with a patient. So let's split this up a little bit. So for visit types, we now have actually a buffet of options available to us. It doesn't sound like much, but there is actually quite a few formats when you start breaking this apart. So of course we have in-person visits, which have something that's served us for quite a long time, although our in-person visits now do look different than what they looked like before. But even our virtual visits, it's worth remembering that there's several different ways this can happen. So phone is a type of virtual visit. The patient's not with you, so you can be doing it by phone. We have our traditional telehealth setup, what we call facility-based video conference, where the patient actually physically goes to a facility, goes to a special room that has the hookup and does their video conferencing visit. There may or may not be a care provider there as well. Or they can do video conferencing from their own home. And the reason that I'm saying there's actually a buffet of options is that actually, when you think about it, there can be any permutation of those things, because in a lot of settings, different staff are seeing patients in different ways. So it might be that I decide that I'm going to bring them in to see the patient physically as the physician, and maybe the nurse will see them physically as well, but the dietitian is still calling them by phone. Maybe the social worker has a video call with them. And so that's why I have this little picture of permutations on the side, is that it can really be any combination of those things that's contributing to what we would previously have called one clinic visit. Now, when we're thinking about how do I find the right visit type, there's quite a few things that feed into this. The one that I have at the top of what is the health authority support, if we were thinking about this clinically, that would not be the first item on our list. But being a realist, it is here in that you can only use what's going to be supported. It's very difficult for you to use a platform that's unsupported, because where do you go for backup when problems happen? The other items, which I would say are the more clinically important ones, kind of follow from that. Now, hopefully we get to have some input as to what the health authority would support based on these clinical items, like what works for our clinic workflow. Previously, we would have patients coming in and out of rooms and seeing many different providers in one place. That's sometimes a bit of a challenge in a virtual platform. Some platforms have what they call a virtual waiting room where you can do that, but having that flow of seeing multiple providers is actually a little bit difficult to replicate in the virtual world. We need to think about what our staff are comfortable with. And importantly, I put here, not just what any one or two staff like, but what works for the whole team. It's no good to me if a video conferencing solution works really, really well for me as a physician, but the rest of my team can't access it, because then we've lost that integrated care. So what's working for the whole team? We need to think about, are we just going to be going with one option, or are we going to have multiple options? The more that we go down this road, I think some of us are realizing that it's not going to be one size fits all. We probably need more than one option, but of course there's workflow implications if you're having more than one different option in your clinic. And the last point I think is a really important one is about documentation. This is something we've learned as we made this switch to virtual health, is that we were all thinking about how do I interact and how do I see the patient, how do I talk to the patient, but the documentation is absolutely key. And that can be more or less difficult depending on what platform you're using. And it has to be, I need a way to document and communicate between team members and to the external providers who might be seeing this as well. So don't forget that when you're thinking about this. I put all these considerations here. I specifically didn't put an answer. I don't put a platform here because again, we're seeing different clinics using different platforms, and that's completely okay. These are just the considerations you need to be thinking of as you're trying to figure out if this platform is a good fit for you. So those are the visit types we're thinking about, the virtual visit types here. But now we need to think about, do I have the right patient for the right visit type? So the question we lead with is, I think one we should always be thinking of is a virtual visit what this patient wants? Well, when we come to our learning so far, I'm going to come back to this point of what is it that our patients want. But then I think there's a few other things to think about in here as well. So we all think, can the patient navigate a virtual visit? And I think a lot of us sometimes have this bit of a prejudiced view in that we'll say, oh, well, we have a lot of older patients and they might not be able to make it. Well, I can tell you, I've had, 90-year-olds work the video conference just fine, thank you very much. And, then 50-year-old patients be unable to log in, right? So I think we need to get that out of our heads, that all of our older patients can't work video conferencing, and there's good literature to support that many of them can just fine. But not everybody can. And I think that's the way to think about it. So don't have it in your head who you think can and can't work a video conferencing visit. It's really up to you figuring that out from the patient individually. One of the things that's come up quite a lot that I think maybe we didn't think about immediately up front is, what about involving other people in the visits? It very much used to be the reality that when a patient would come to clinic, especially if they're at a transition point, you're talking about treatment modalities, they would bring their spouse, or they would bring, their parents or their children or what have you, some combination of loved ones, which now integrating those people into the visits is sometimes a little bit difficult if they're in different places. There's some advantages, because video conferencing, you might be able to reach people who previously were quite far away, but it's difficult to integrate. So pros and cons there. And then the last one I think is an important one too, is around language barriers. And I don't just mean, do I have to get an interpreter on the call, but also a lot of the support materials. You'll see that a lot of the health authorities have put out virtual health support materials, most of which are exclusively in English. So it's one thing to need an interpreter, but it's another thing if they can't even read the material about how to log in, well then, it's a little bit, you're not gonna be able to get them onto the visit. So those are some broad cuts here, but I think the reality of it is we're going to need to get to the point where we have an accurate way of selecting these right patients, not just asking them, is this what you want? Some places are working on tools, and I hope that we'll have much more to share on this very soon. I know, for example, in Vancouver Coastal, they've been working on what they call an appropriateness assessment, which I think is the right way to go about this, is some standardized and objective way of saying, is this a patient who can have a virtual visit? And I think as we move down this road, one of the underlying thoughts we need to keep is we need to make sure we're not actually making things worse here. As we go full bore into virtual visits, either now or in the future, we need to make sure we're not worsening disparities. And what I mean by that is we need to make sure that people who cannot access virtual care are not getting the short end of the stick. Because a lot of those people who have difficulty accessing virtual care are probably already disadvantaged in terms of the healthcare, their healthcare literacy and healthcare access, and we don't want to make things worse. So I think that's a very, very important point here. I mentioned also primary care, and I've said this a couple of times now. This is another thing that's come out as the months have gone on, is that we've always relied in renal care to have that collaboration with the primary care provider. And for some patients, they are just unable to access the primary care provider. And so again, we now don't want to have somebody who can't access primary care and can't access us, and really, really disadvantages that patient. Okay, so the right patient and the right time, or the right platform and the right patient. Now the right time is the third consideration here. And there's a few things here. Some of this is quite obvious in terms of, do I need to examine the patient? But some of it may be not so obvious. Things like, is it time for a difficult conversation? Because we've really found that there's just nothing that beats face-to-face when it comes to having a difficult conversation. Are they stable or unstable? That's going to influence your decision. The last 2 points are things that I think we weren't envisioning immediately when we made this transition, but as we're now many months in, one of them is, when was the last time I saw this person face to face? We're now getting to a point where some of our patients we haven't seen in well over a year because of the, you may not have seen them leading up to March, and now here we are 9 months later. And so it might be a long time since you've actually seen the whites of their eyes, so to speak. And that is a concern to a lot of the care providers. And then we also have to think about how many people can actually bring in that day. So if my clinic day is full for physical visits, this clinic, maybe I need to bump somebody to a different clinic so I can actually bring this person in if they need to come in physically. It's a consideration we never really had to have in the past, but what's my capacity for physical visits? And then the other part of the right time that I'm thinking of, and I want to kind of write this up as the norm effect, so to speak, is, how long have you known this patient, right? So there's some patients we have in our clinic that are like Norm and Cheers. They walk in and everybody knows them because we've been seeing them for many, many years. But then there are some that are completely new. And I can say there are some patients that now I'm getting that are getting close to modality education that maybe you've never even seen them physically because they got referred to you, you've met them by video conference, you sent them to kidney clinic. All this has happened in a few months, but you've never actually seen them face to face, shaken their hand, and that does, I think, make a difference. The patients we've known for a long time, we find that we can jump into a video call quite seamlessly, and they can pick up because we have that interaction, and you can have even difficult conversations. Whereas if you don't have that existing rapport, it can be a little bit more difficult. So to put this all together, we now really have a complex set of decisions that needs to go into every time we're seeing a patient. And it doesn't mean that I'm saying that people are going to have to spend half an hour deciding, what to do before they even see a patient. But now we're not just have a one-size-fits-all clinic. We're actually thinking every single time, what's the best way to see this patient today? And that's something we're going to have to build into our clinic workflow, is figuring out what's going to be the right way to go for this patient for this visit. So I think, it's a good point to reflect on some of the learnings so far. We've really need to, I think, be quite honest about this. There's good, there's bad, and there's ugly. And I think we need to have a frank conversation around this. The good, and I really, really want to emphasize this, is that it's almost unheard of the amount of change we've made in a few months to keep people safe. And I really want to, congratulate everyone on that. This is completely unprecedented, and everyone's done a stellar job to make sure the patients can still be cared for. But there are some other advantages with virtual care. They can be faster, some of these virtual visits. They can be more convenient. And one of the things we've learned is it can facilitate some supplements to in-clinic care, like webinars, things that people can attend without having to come in. And our webinars are better attended than they ever have been. So those are all positive things. But there is some bad, and I think some people have realized this. The main one that I see is that the novelty's worn off and people are sick of phone calls. Both patients and staff are sick of talking to people on the phone or by video. One of the advantages of the virtual care is that it can be quite fast or efficient, but the downside is that you might lose all of that efficiency spending time doing IT support, or what I call air traffic control, making sure the right person is talking to the right provider. We've already talked about the difficulty forming relationships, and part of it actually that I worry about the most is that some patients just can't engage to the same degree. And it's not a fault of their own, but some people are just able to talk on the phone and have a good visit. Other people just can't. And I think we've all recognized that. And then there is, of course, the ugly. We know that in many situations, virtual visits are just not good enough. We're still awaiting evaluation to tell us this for sure, but we know it's not a replacement. And so in a lot of cases, the type of visit we're having is not the type of visit we want. And that's a bad feeling as a care provider. We also are starting to find that some of our team members, or to different degrees, are maybe feeling excluded or not able to play the role in the team they would like to. And so I think this is taking a toll on team morale, and we've kind of seen this. And to compound that, people have been working in crisis mode for 9 months now, and there's only so long you can work in crisis mode. People are sick of change, and people are sick of working in crisis mode. In some cases, it's hard to know exactly the care we provided. When I've called somebody and they only want a phone visit, and I can tell they're in the car on their way to driving somewhere else, and the patient's basically trying to get me off the phone within 2 minutes, I know I haven't provided proper care to that patient. And I think we've all had that experience. So we know that in some cases, we're just not providing the right care. And the last point, I bring this up, I don't know for sure, but I worry that we continue to worsen inequities in chronic disease care as we do this. And this is not just me saying this. I've stolen this slide from Dr. Singh, who you've heard present on this previously at BC Kidney Days and at province-wide rounds, but he found a lot, when they did this Northern Health with their traditional telehealth format, they found a lot of the same things, right? So this theme keeps coming up, that this is an adjunct, but this does not replace this does not replace physical care. It is not the same as physical care. And that development of a relationship is one of the main struggles. So I don't want to make this sound doom and gloom by ending on the bad and the ugly. We need to talk about, where do we go? So how do we implement these solutions both now and in the future? And how do we do this in the right way to address the needs of both our patients and the needs of our teams? So however we do it, we can say two things. It's going to be iterative and it's going to be data-driven. And why I say however we do it, it's because none of us know what the right answer is yet. This is all new to us. Even 9 months in, this is still new. So I think we need to be adaptable and willing to make this an iterative process as we learn from it. And now that we're in this kind of maintenance phase, we need to be doing this in a data-driven way where we actually have information to guide what we're doing here. So to get there, we have an evaluation plan for our virtual kidney care. To be honest, I was hoping by now that there would be much more standardized evaluation formats of this across the province, not within renal, I mean actually with all of the chronic disease care we offer in BC, since this is such a big item, but it's not quite happening yet. So I think this is one of these situations where we can lead the way in renal. And so we're starting to think of this. We're collaborating with PHSA. They have an Office of Virtual Health that's tasked with this. We're starting to think about this a little bit more. And so I think when we talk about how we're going to evaluate this, there really are these three components, and I'll go through each of them in turn. The first is actually just to figure out, where are we right now? Again, since there's so much variability out there, I think it's worth taking stock of exactly what's being used, how is it being used, and what's working well, what's not working well. I actually even put in there, we also need to talk about how physical visits are being done, because physical visits aren't one thing anymore. There's different combinations of ways that happens. We need to think about how this is integrated within clinics. So a thorough steady state, or a thorough current state evaluation. And this is being planned and right now, actually. So this is something we'll hope to have within a couple of months. Because once we know where we are, then we can describe the impact it has. We can't jump right to this. A lot of people want to jump right into saying, what's the impact on patients, providers, and everything. And there's surveys out there that are being administered. But I think first we need to actually know where we're starting from before we can do this. Once we have that information, then we of course need to figure out and go right to the people this is affecting, what their experience has been. And I really separate it into these three domains. There's patients and their families, providers and teams. And the provider and the team are actually two different things. Because again, we need to get at what's the function of our integrated kidney team, not just the individual providers, but the team together. How is that going for us and how is that working? And as we're doing this, there's going to be several domains we have to talk about. The visit types that we're having, the visit formats we're having, and how do we figure out who's going to be the right person for the right visit. So this is going to be a big body of work that comes next. And then the last one is ultimately going to be, how has this impacted our key metrics? So everything we do in BC Renal, we have these key performance metrics within our modalities. We have them for kidney care and PD and home hemodialysis. We've been following them for years. So that data is readily available. But why this is going to be a longer term issue is a lot of those numbers take a long time to change. Even if you make a change today, that might not necessarily be reflected in the data until years from now. And it's going to be a bit of a work to figure out exactly were those changes a result, or those changes in the metrics a result of virtual care. But now is the time to do all of this. So that sounds like a lot of work with the evaluation, but I think we're finally at a place where we can do this. We were hoping to do this earlier on, but frankly, in the midst of the emergent change, that wouldn't be possible. So now is really the time when we're in steady state and we can, it can take some time to reflect. And really, this is the opportunity now to find these learnings and enhance the care we're going to be offering in the future. Not just now during COVID, because this won't be forever, but in the future as well. So with that, hopefully I left people with somewhat of an optimistic view of where this might be going. I think it's important to remember where we came from and to think about how we're going to bring this into the future and do this in an objective type of way. And with that, I want to just leave it also with thanking everybody involved in this. I don't think I've thanked people nearly enough for all the massive changes they've made in the last 9 months, and the commitment this has shown to our patients, and to keep them well cared for has just gone such a long way. So thank you to all of you out there for the tremendous work you've done. And then we'll turn it over and open up to questions.
Thank you, Mike, for this really amazing presentation. So we have time for questions. So please submit your questions using the live Q&A feature in your app. I see we already have questions coming in. So I will read out the questions, Mike.
Great.
So the first question for you is, given the limitations of virtual appointment from clinical perspective, as clinical teams, how do we balance the ease of use versus hard clinical outcomes? That comes to my mind too when I read this out, particularly when our patients have great experience using virtual care. So patients clearly love the ease of it, but we are worried about this being a chronic disease. What are going to be the outcomes that we haven't analyzed? So how do you propose we balance that risk?
Yeah, and that's one of the reasons that I think we really need to look at those various different domains. It's one of the concerns I have about some of the evaluation tools that go out there. A lot of the health authorities, for example, if you've done a virtual visit, it automatically sends you to a survey, which was really just, did you like logging on to this tool? Was it convenient for you? You know, kind of the quick and dirty satisfaction survey that really has nothing to do with the care being provided. I think it's one thing to ask somebody, did you like attending a visit by computer because you didn't have to drive in? Of course, they're going to say yes, but it's a very, very different thing to get to what was the care you felt you were provided. And from the team perspective, what is the care that you felt you provided to the patient? So I think that having those two components to it is really what's going to help us temper just that. Because I am worried that if only everybody looked at, was this a convenient and easy thing to do, they would say, yes, this is fantastic and we should do 100% of our visits this way, but we'd be missing that part about the care we've actually delivered. So I think by bringing that to the fore of our evaluation plan, it's going to help us kind of temper that concern.
That's great. So you touched on the importance of remaining this as a team-based sport, like providing care in the team setting and how important it is to intertwine everybody in that model. So clearly providing virtual care, lack of human element, puts more psychological stress. So we've seen, yes, in the pandemic situation, but even before that, the needs of the patients just simply cannot be addressed. We need more support, follow-up, in between appointment conversations. So do you think it's time to reflect on the whole model, given that we've, in an unplanned way, we've incorporated virtual care to our clinics? What do you think about that?
Yeah, I think that's a really good point. I think that the key part of this is really just having an integrated and cohesive team. But the way that team functions, I think is going to be forever changed after all of this. You know, I think we've seen a good example is that there are a lot of tasks we used to do during the clinic, things like take a medication, a best medication history, and things like that, that almost universally have been removed from the clinic setting and are now being done either before visits or between visits and things like that. And I think that's a good thing. So, and I do think that, just like you said, the way our team actually delivers the care is going to look different even after all this is all done. I think this is going to be a good time to take stock of where can we gain some of those efficiencies and offer better between visit care than we were before. So I definitely think that's going to change. But the key component of having that integrated team, even if the different providers are seeing are talking to the patients on different days, the fact that they're working together as one team is the part that we don't want to lose.
Yeah, I totally agree. I think the resources are important. We need to be equipped to deal with this kind of model of care. So there are other questions coming in. So the next, I'll read it out to you. Do you feel virtual care will change the general attitude, particularly when it comes to people accessing healthcare in general? They would want more like point of care versus scheduled appointments.
That's a million. Kind of loaded. It's, there are good and bad things about going to that model. Some people might talk about it as a consumer model of healthcare, right? Like just like I want to, you know, be able to call up my accountant on my phone whenever I want, and pull him up on the video, and I don't have to go in. Like you said, that's great, and there might be times where that works well, but there are times with some of the complex tasks that we do where it just doesn't lend itself to it, and that's where that you know, really getting into a detailed evaluation of what tasks lend itself to that type of format, and which tasks do not, is going to be just as important. For some things, I think it will be a good thing, right? I think that some patients might find it easier to engage if they know, for example, they can pick up their video phone with their dietitian whenever they're having a question and ask a question quickly. I think that might be a big value to some patients in a clinic, but there are some things that can't always be on demand right when I want it, you know, point of care service, because they're just too complex to be offered in that way. So that's where dissecting those different care items, I think, is going to be very, very important.
I agree. Okay, so we have another question. Have any similar evaluation exercises been conducted elsewhere? I think it's referred to the evaluation that you talked about. Has anybody looked at the virtual care models elsewhere?
Not as holistically as we would like. This is all kind of shaping up. And I kind of mentioned this, I was really hoping that there would be something, you know, especially knowing that even just across BC, that so much resources has gone into this, and it's something everybody has had to do, that we would start having some kind of more, you know, across the board evaluation format for this. But the short answer is not quite yet. And that's okay. If this is one of those examples where we're kind of leaning the way in renal, as we've done before, we're very fortunate to have this fantastic structure of our clinics. We have a provincial structure where we all know each other and work together. And so we are kind of uniquely placed to take this on. It means shouldering some of that load and doing it ourselves. But I think ultimately, you know, what we do may actually serve as a template for other people and not the other way around. I think, to be honest, if we're waiting for a pre-made evaluation format to be given to us, we'll kind of have missed the boat, because I think that's going to be a ways in the future.
No, I completely agree. And I think the evaluation needs to be multi-pronged, from patient ease perspective, from provider perspective, and the system's perspective, right? So there is no point if we can't learn from all perspective to change on the go. It's like, as I say, we're building the plane at the same time trying to fly it, right? So getting as much information is important. And I think it's very also a plug-in for qualitative information, because we rely a lot on the numbers, on tick boxes. Sometimes they cannot be really translated into an experience or really an outcome for the patients. So yeah, I don't know. What do you think about that?
I couldn't agree more. You know, I didn't get into the details of what the evaluation plan is going to be, but I can certainly say it's going to involve focus grouping. And I think especially when we're getting to the part where it's talking about how's the team functioning, we're actually going to probably need to bring someone in outside of renal, somebody who actually, maybe from the business world, for example, who has that mindset of, how do I actually analyze, is this team in front of me functioning well? That's something we haven't actually really, you know, taken stock of in quite a long time. And so I think it is going to be qualitative, and it's probably going to involve expertise outside of our own in renal to really get this done well.
Perfect. I want to thank you, Mike, for this enlightening presentation, and thank you everyone for watching and participating in this session. I don't want to keep you from your lunch. Your lunch is up next. The cooking demo will begin at 11:35 via the live webcast link at the top of the schedule and event. Enjoy your lunch. A live plenary begins at 12:35, and I'll see you there. Bye.